Mitral stenosis in continuation of valvular heart disease, a very common valvular disease in our country, and prevalence is very high. A sequelae to rheumatic fever in our country. Most common reason for mitral stenosis is a rheumatic fever. So the mitral orifice 4 to 6 square centimeter. Keep it in mind. When the valve area becomes less than 2 square centimeter, the pressure gradient develops between the left atrium and the ventricle during the diastole. The pressure indicator of severity is critically affected by the cardiac output. If it is more or the pulse rate is high, these are the two things when the gradient increases. Keep this in mind, that the cardiac output and the heart rate increases the gradient across the mitral valve. So MS severity is the mitral valve area we have to look into by the echocardiography, by the pressure half time and the hemodynamic effects on the left atrium, that is the left atrial enlargement and pulmonary hypertension. These three parameters will tell us the mitral stenosis severity. What are these? Mitral valve area calculated, the diastolic pressure half time, left atrial enlargement and the pulmonary hypertension. The fact is the therapy also depends upon. So this is one thing which you have to see carefully. It is a very complex apparatus. I call mitral valve as a apparatus. So the leaflets, chordae and the papillary muscles. There are three parts. These are the leaflets. These are several chordaes and two papillary muscles, posterior-medial and anterolateral. So how you see them? You have to see them as scallops in the commissures. So in the leaflets, so the middle one in the posterior leaflet is the P2, the lateral one P1, the medial one P3, and same are on the anterior mitral leaflet. These are to be kept in mind because, okay, this is the figure. The middle one, posterior one is P2, my dear friend. In the same way, the anterior leaflet is A2. You can see the closer line is more on the posterior side of the whole of the annulus. So it's very clear that this is P1, this is P2, this is P3. It has got all implications as far as the mitral valve, mitral regurgitation is concerned. So this is some intricate anatomy of the mitral valve, which is very useful to remember when it comes to the. So the clinical presentation. What happens? Very severe mitral stenosis, by definition, less than 1 square centimeter. Pressure half time of 220 milliseconds and LA enlargement and increased pulmonary artery pressure. This is in nutshell the severe mitral stenosis. And very severe, of course, less than 1. Severe mitral stenosis 1.5, pressure half time 150, LA enlargement and pulmonary artery pressure is raised. Progressive, by the recent definition by the ACC-AHA, progressive is a mild to moderate 1.5, less than 2 but maybe more than 1.5, and the pressure half time is 150 millisecond. No left atrial enlargement, no elevation of the pulmonary artery pressure. Increased LA pressure is transmitted to pulmonary vasculature. Mind you, it is in immediate vicinity of the pulmonary vasculature, the mitral valve, not very distant. So pulmonary vascular pressure causes pulmonary hypertension reactively. Long-standing severe MS, there are obliterative changes causing right heart failure. This hemodynamic sequelae has to be remembered. Decreased preload because of the stenosis and the myocarditis also there. So the symptoms of poor perfusion will be there because of the reduced cardiac output and the increase in the systemic vascular resistance like Meller flush and all those things. So the causes rheumatic fever and the incidence is equal male and female, my dear. It's very clearly mentioned. Incidence of rheumatic fever is clear, but mitral stenosis is 3 times. This is more common in females. Rheumatic fever, same. It's the sequelae of group A streptococcal infection. It takes 5 to 10 years. In India, we can tell you, we observe the patient more early, quite early than 5 to 10 years. So, the parachute mitral valve, congenital mitral stenosis, seen but less. All the Coldes are inserting into a single papillary muscle. Supravalvular mitral valve ring should be looked into. It is important. And this is another, there are 3 atriums because of the partition of the left atrium into 2. It is also a very interesting phenomena, and congenitally we have seen some cases. Systemic disease which can cause the valvular fibrosis, lupus, carcinoid, rheumatoid also, mucopolysaccharitis, endocarditis sequelae after 4-5 years, anorectic drugs, don't forget fenfluramine can cause mitral stenosis, severe mitral annular calcification, now it is common in the western countries in the old age, but the mitral stenosis of the young is rheumatic. So there is a latent, quite a asymptomatic phase for many years. They don't present and remains subclinical. Dyspnea because of the increased venous pressure. Exertional nocturnal dyspnea, the first sign when the patient comes to the hospital. What are the precipitating factors? Exercise and emotional stress. Pregnancy. First time the females present during the pregnancy when there is a hypertonic circulation and the gradient increases and the pulmonary edema sort of thing develop. So early dilatation and these things are the predisposing factors. Hemoptysis can occur because of the rupture of the small bronchial veins. Hoarseness because of the compression of the recurrent laryngeal nerve. This is known as a fancy name like Ortner syndrome. So in atrial fibrillation, because of the stagnation, there may be thrombus formation in left atrium and left atrial appendage. AF increase of 1 year duration may cause thrombus formation more. LA size if it is more than 4.5, thrombus formation and distal embolization. The spontaneous echo contrast, if you see on the echo, it's predisposing to thrombus formation. And if there is a prior thrombotic event, then the atrial fibrillation may be presented. So these are all the presentations of atrial fibrillation, which I call as a turning point as far as the mitral stenosis is concerned. So LA dilatation and stasis, as we already talked, thrombus formation, embolic events devastating in cardiovascular, renal infarctions may take place, saddle valve, big thrombuses have been seen in the bifurcation of the aorta, and the malformed valve predisposes to endocarditis. Never forget, mitral stenosis, dentals and those procedures may cause endocarditis. Mitral stenosis is also the one. Reduced cardiac output lead to fatigue. Important one. Elevated pulmonary artery pressure will lead to chronic elevation, will lead to RV failure. So elevated pulmonary pressure will give you a pain like it, just like a angina one. They may present as a pain chest. Malar facial flush may not be seen, but it is there because of the low cardiac output. JVP prominent if still in atrial sinus rhythm, you see the A waves. JVP raised with the elevated RV failure. Of course, as we know, carotid upstroke is of low volume because of the low cardiac output. Diastolic thrill may be palpable. First heart sound may be palpable at the apex. Opening snap ushering in the mid-diastolic murmur is the crux of the mitral stenosis. We learned right from our beginning of the medical studentship, and we find this, and our teachers also teach the opening snap and the mid-diastolic murmur. Lungs, there may be crackles because of the failure, although the edema clears early because with the help of the lymphatics. So peripheral pulse, there it may be irregular. You know it. The most common cause is aortic, is the atrial fibrillation. MDM after opening snap. Severe the mitral stenosis, earlier the opening snap and longer the murmur. Longer the murmur. Earlier the opening snap. Severity of mitral stenosis. S1 is palpable and always heard. It even after atrial fibrillation, the S1 remains loud because of the snapping of the valve itself. So this is a very important diagram, and in the last what we have done is, because of the contraction of the left atrium and the patient is in sinus rhythm, then you will have the presystolic accentuation. Presystolic accentuation before the S1. So these are the findings which we start looking right from the beginning. What will you find in ECG? Maybe in the sinus rhythm. Atrial fibrillation, very common. Nosed P because of the left atrial enlargement in the second, third, and maybe biphasic in V1. The second phase of the P wave more prominent because of the left atrial enlargement. There may be a right ventricular hypertrophy and the tall R waves and deep S waves in V1 and V6. All the features of right ventricular hypertrophy. RA enlargement, P wave was broad and seen in lead 2. V1 also, as I told you. So what will you find in chest X-ray? Because these are all teaching points as far as the mitral stenosis is concerned. That there is a straightening of the left upper border because of the enlargement of what? Left atrial appendage. LA enlarges and there is a double density because of the LA. Many a times 3/4 of the heart shadow may be a enlarged left atrium. So should be kept in mind. Left main bronchus may be elevated. This is also a sign which is akin to Ortner sign. Chronically elevated pulmonary venous pressure, cephalization, curly B, like the interlobar edemas. Right heart failure will cause the retrosternal lateral projection, and it is also above the diaphragm, very clearly seen. So LA appendage, left atrial enlargement, right ventricular enlargement, cephalization of the pulmonary veins or curly B lines, these are all present as far as the X-ray is concerned. So secondary prevention of the rheumatic fever, which will prevent the incidence of mitral stenosis, is benzathine penicillin, 1.2 million unit every 3 to 4 weeks depending upon the endemicity of the streptococcal infections. 6 lakhs if the weight of the child is less. Alternatively, what we can give is a sulfadiazine also, don't forget, can be given. If there is a atrial fibrillation, what will you give? Nodal blockers like beta blockers. We have to reduce the ventricular rate to below 100, maybe around 90 to 100. In the same way, if beta blockers are not tolerated, we can use a verapamil or a diltiazem. Digoxin is used for the rate control, and it's the ideal drug as far as the mitral stenosis with atrial fibrillation is concerned. But along with beta blockers, then only the rate will be controlled in an ambulatory patient. Warfarin has to be given to prevent the strokes. You know, the INR keep 2 to 3, and you cannot give the newer oral anticoagulants as far as the mitral valve is concerned. Not recommended, I have clearly written. In congestive heart failure also you have to give the medication and treat it. Interventional therapy should be considered if the mitral valve area is less than 1.5. This is the ideal time. We should start looking for balloon angioplasty. Is the procedure of choice. It doesn't give a scar on the chest because these are the patients who are young girls, and cosmetically also it is very important. Even if it is asymptomatic, if the mitral valve area is less than 1 square centimeter and the pulmonary systolic pressure is more than 50 or 60, you just dilate the valve. Onset of atrial fibrillation is important. Transmitral gradient, if it is more than 15 millimeter, indication. The pulmonary artery pressure more than 50, we have talked already. Cardiac surgery, if other cardiac surgery is there and the mitral valve area is only 1.6 to 2, operate. Percutaneous balloon mitral valvotomy, we have already told that if the valves are pliable, leaflets, then do it. If there are no left atrial thrombus, do the balloon angioplasty, balloon valvuloplasty. So the mean pressure gradient decreases by 7 to 10 millimeter and the valve area increases by around 1 square centimeter, which is very relieving to the patient. The survival rate is quite good with balloon mitral valvuloplasty. Complications are there in the form of mitral regurgitation, hemopericardium, death may take place. So these are the things which are to be seen. Surgical commissurotomy, closed and open, both are there, but these days because of lot of involvement of the chordae tendineae and the apparatus is so deformed that the mitral valve replacement is the only choice many a times left with the surgeon. Prosthetic and mechanical valves. Prosthetic mechanical valves, warfarin is the problem. Lifelong anticoagulation, important, difficult in pregnancy, so a bad choice. Bioprosthetic valve, no warfarin but degenerates during time, and in youngsters it is very difficult. So it is a very difficult, I should say, a choice between the mechanical prosthesis and the biovalves. So this is all about